Morning, everyone. Now I request Dr. Seema Patwari to please come on the stage and deliver a talk on diabetic retinopathy. Dr. Seema Patwari, consultant ophthalmologist and director of Jharkhand Diabetic and Eye Center, qualification MBBS, DO, Fellow Medical Retina, Chennai. She has got a lot of achievement. She is a treasurer of Dhanbad Ophthalmology Society, treasurer of RSSDI 24 Dhanbad, member of AIOS, JSOS, DOS, IMA, and RSSDI.
Thank you, sir.
She's also a very popular member among the Rotary also.
Thank you, sir. Good morning, everyone, and good morning to the chairpersons. I would like to thank RSSDI Jharkhand chapter to give me this opportunity to speak on this platform. कहते हैं आँख है तो जहाँ है, बिना आँखों के दुनिया की सारी खूबसूरती बेमानी है. तो please let's come and join our hands to protect the vision of our diabetic patients due to diabetic retinopathy. As we all know, diabetic retinopathy is a leading cause of blindness in the world. Today, I will speak on the following headings of diabetic retinopathy. First of all, about the prevalence of diabetic retinopathy. Diabetic retinopathy is a leading cause of blindness in adults of the working age group. According to the recent data shared by the American Academy of Ophthalmology, prevalence of DR is 77.3% in type 1 patients and 25.1% in type 2, out of which approximately 25 to 30% are expected to develop vision-threatening diabetic macular edema. In India, overall, prevalence of DR is 12.5%, and in non-diabetics, it is 12.5%, whereas in undiagnosed, it is 8%. In urban population in India, prevalence is around 12.8, whereas in rural, it is 12.4. So we can see that there is no difference between the urban and the rural population in case of diabetic retinopathy. Now, what are the risk factors for developing diabetic retinopathy? First of all, it is the duration of diabetes. As the duration increases, the chance of developing diabetic retinopathy also increases. The second is poor control of diabetes. If the HbA1c level is not controlled, then even in 1 to 2 years, we can see diabetic retinopathy. And if there is associated hypertension, nephropathy, obesity, and hyperlipidemia, then the chances of developing diabetic retinopathy increases. And even if there is associated smoking or pregnancy. Pregnancy means if a patient with diabetes is pregnancy, then the chance of developing diabetic retinopathy increases. Now about the pathogenesis. Microangiopathy is the main pathogenesis behind retinopathy. It's to microvascular leakage and microvascular occlusion. Sometimes the larger vessels may also be involved. There is loss of pericytes, which results in distension of the weak capillary walls, producing microaneurysms which leak. There is a blood-retinal barrier which breaks down in diabetic retinopathy that leads to leakage of plasma constituents into the retina, leading to retinal edema and hard exudates. The microvascular occlusion which occurs in diabetic retinopathy is due to basement membrane thickening, endothelial cell damage, deformed RBCs, platelet stickiness, and aggregation. When the retina becomes hypoxia due to microvascular occlusion, then there is release of vascular endothelial growth factor, which ultimately leads to the growth of shunts and new vessels. Now about the classification of diabetic retinopathy. It is broadly classified into three main headings: non-proliferative diabetic retinopathy, proliferative, and clinically significant macular edema. Non-proliferative is again divided into mild, moderate, and severe. In mild NPDR, as we can see in the picture, it's a fundus photograph. At least we see one microaneurysm, which is the earliest clinically detectable lesion, and there may be associated retinal hemorrhages and hard exudates. And in moderate NPDR, there is retinal hemorrhage or microaneurysm in at least one quadrant. Along with that, one or more of the following features are present, like soft exudate, venous bleeding, intraretinal microvascular abnormality. In severe NPDR, it fulfills one of the 4-to-1 rule, that is hemorrhages or microaneurysms in all the 4 quadrants of the retina, venous bleeding in at least 2 quadrants, and edema changes in at least 1 quadrant. In PDR, that is proliferative diabetic retinopathy, there is one or more of the following. Retinal new vessels elsewhere. Means besides the NV, the new vessels can develop anywhere in the retina. If there is new vessels of the disc or vitreous or pre-retinal hemorrhage. Now, clinically significant macular edema, which is the main pathology seen in diabetic retinopathy. It is described as retinal edema within 500 micrometer of the center of the fovea. This is the macula, and this part is for the vision, and the center is called as fovea. So when there is retinal edema within 500 micrometer of the center of the fovea, or hard exudates within 500 micrometer of the center of the fovea, or retinal edema, which is of size 1 disc area, any part of which is within 1 disc diameter of the center of the fovea. Now, how to evaluate for diabetic retinopathy? So first and foremost thing is to go for ocular examination, in which we do visual acuity, intraocular pressure, slit lamp examination. In the slit lamp examination, we can have an idea about the anterior segment, like if the patient is having any cataract or glaucoma or NVI, new vascularization of the iris. The most important ocular examination for diabetic retinopathy is dilated fundus examination with indirect ophthalmoscopy. We can see here the picture in which a doctor is examining a patient with an indirect ophthalmoscope. Now, the next is fundus photography. We do generally for documentation and the record purposes and for patient education and counseling. But in many centers of the diabetologist, they just do a fundus photography for screening purpose. Now, the next investigation which we do in diabetic retinopathy is fundus fluorescent angiography, generally done to diagnose ischemic maculopathy, to locate capillary dropout areas. First of all, actually in fundus fluorescent angiography, we inject a dye, fluorescent, into the vein, and then we take the photography of the retina vasculature. It helps in diagnosing ischemic maculopathy, capillary dropout areas, and to differentiate between edema from NVE, occult new vessels, or to locate leaking microaneurysms. If there is leaking microaneurysms, then we have to go for laser therapy. Investigation is optical coherence tomography, that is OCT. It is done to evaluate retinal thickening for the assessment and monitoring of macular edema after initiation of treatment with intravitreal injections. Now, the latest technique which has come out, optical coherence tomography angiography. In this, we do not need to inject a dye. Means it is a we do not need to inject any dye, but it employs a motion contrast imaging to retinal blood flow. And the last one is ultrasonography, that is B scan. It is done when the media is hazy, when we cannot visualize the fundus. It is used in to detect vitreous hemorrhage, tractional retinal detachment, subhyaloid hemorrhage, posterior vitreous detachment. The treatment or management part in NPDR, that is non-proliferative diabetic retinopathy, the most important management part is strict metabolic control of diabetes. We have to maintain the HbA1c level below 7. In both type 1 and type 2 patients, an optimal TIR, that is time in range, should be maintained. Any associated systemic ailments like hypertension, dyslipidemia, anemia, nephropathy, hypoproteinemia, cardiac ailments should be taken care of along with diabetes. In severe NPDR, scatter PRP is sometimes indicated in patients with uncontrolled blood sugar, nephropathy, pregnancy, cardiac failure, poor compliance for follow-up. Suggested follow-up schedule in NPDR is, in case of very mild NPDR, it should be every year. And in mild to moderate NPDR, it should be between 6 to 12 months. Severe to very severe NPDR, follow-up within 2 to 4 months. The diabetic macular edema, center involving diabetic macular edema, in that case, we have to give anti-VEGF agents. They are the first line of treatment. Commonly used anti-VEGFs are bevacizumab, ranibizumab, and aflibercept. And the non-center involving diabetic macular edema, we go for focal or grid laser. In PDR, pan-retinal photocoagulation is the standard treatment of PDR. Sometimes anti-VEGF along with PRP may be needed. In advanced diabetic eye disease, sometimes vitrectomy is needed. In that case, the indications are non-clearing vitreous hemorrhage, fractional retinal detachment, anterior segment neovascularization with the invisibility of the posterior segment, and vitreomacular traction. And what are the complications of diabetic retinopathy? When the new vessels causes vitreous hemorrhage, and that causes tractional retinal detachment and rubeosis iridis, neovascular glaucoma, and ultimately blindness. Vision impairment is seen in diabetic retinopathy due to non-clearing vitreous hemorrhage, neovascular glaucoma, tractional retinal detachment, macular edema, and macular ischemia. How to prevent diabetic retinopathy? First of all, it should be, the glycemic control, it should be the HbA1c level below 7. And we should maintain the optimal time in range above 70%. That is the blood sugar level. It should be maintained between 70 to 180. In 70% in 24 hours, 70% of 24 hours, it should be between that range. And along with the blood sugar, we should treat the other associated systemic ailments like hypertension, hyperlipidemia, etc. Now, screening for diabetic retinopathy should be done for each and every diabetic patient at a regular interval. Now, what should be the screening protocol for diabetic retinopathy? In type 2 patients, it should be first at the time of diagnosis of diabetes and thereafter every year. And in type 1 patients, first it should be after 5 years of diagnosis of diabetes and thereafter every year. Patients with nephropathy should be screened for diabetic retinopathy. In pregnancy with diabetes, screening should be done first in first trimester and then at 28 weeks and thereafter every year. Now, how to prevent complications? We can prevent complications only by early institution of appropriate treatment. And this requires early detection of diabetic retinopathy. It is actually irreversible. Means if the vision is impaired, then we cannot actually regain the vision of the patient. So it should the treatment should be started early. So for that, we have to detect diabetic retinopathy in the asymptomatic treatable condition. This can be done by routine fundus examination of all diabetic patients and appropriate referral to ophthalmologist. Just I want to say that there are some effects of OHA on DR. Some studies have shown that few OHA like short-acting sulfonylurea and pioglitazone and rosiglitazone, they cause increase in macular edema due to fluid retention. And SGLT2 inhibitors were found to decrease the macular edema by inhibiting the SGLT2 receptors expressed by the pericytes, and thus it prevents the loss of pericytes. Now we can see a normal vision and a defective vision with diabetic retinopathy. Thank you.